Hello everyone, my name is Christian Vadianu and I'm a senior emergency medicine resident here at the University of Alberta. For the next 15 or so minutes, I will be giving a brief tutorial on the Rush exam, one that you will hopefully find useful in your management of the undifferentiated patient in the critical care setting. I'd like you to imagine an unstable trauma patient arriving to your hospital. Your trauma team is activated and quickly a primary survey is underway. Most providers would reach for the ultrasound and perform an EFAST exam on this patient, as it's revolutionized our cultured approach to sick trauma patients. But what about this patient? Meet Mr. Brown, a 64-year-old male with a history of colon cancer admitted to hospital with a UTI and delirium. You are on the team responding to a MET call. Patient is confused, less responsive, and short of breath. He looks really sick. You touch this patient on monitors, and this is what you get. His blood pressure 78/41, he's tachycardic and tachypneic, saturating 94% on room air. That BP certainly is concerning. This patient is certainly in shock. But what kind of shock? The differential for this patient is not as narrow as the trauma patient, but is actually quite vast. Is this patient septic? Does he have a PE? Does he have an acute myocardial infarction, or is he just dry? Would you use an ultrasound in this scenario? With the advent of POCUS in the last decade, I argue a lot of providers would try, but perhaps not as early on and not in the structured way that we do with the EFAST exam for those patients with that trauma imprimatur. But I argue that we should. There's a strong body of evidence that ultrasound also has utility for sick medical patients. My goal in this tutorial is to provide you with a sequence to perform the exam and to back this up with some personal, real-world experiences of when this exam can be useful. One disclaimer, this tutorial was not designed to discuss the technical aspects of image acquisition. This tutorial assumes you have acquired the basics of cardiac, thoracic, abdominal, and aortic ultrasound. I refer you to other resources for help with acquiring and interpreting these images. So what is the Rush exam? Rush stands for Rapid Ultrasound for Shock and Hypotension. While EFAST has been around for a while, a defined protocol for medical patients wasn't introduced until early 2000s. This is one of the founding papers by Dr. Scott Weingard. Here is a taste of some of the primary literature that demonstrates its usefulness. This was an observational study that enrolled a bunch of undifferentiated hypotensive adult patients. All patients had POCUS at the initial time of assessment, and they found that a lot of the time, the diagnosis that was made initially by ultrasound was eventually correct when they looked retrospectively. Papers of similar methodology have replicated these findings and have demonstrated near-perfect sensitivity for hypovolemic and obstructive shock and adequate sensitivity for cardiogenic shock. Let's get into it. The Rush is a structured exam designed to be completed in less than 2 minutes. The acronym HIMAP can be helpful in remembering the sequence. You will start by examining the heart, and this will include subcostal forechamber and, if time allows, peristernal long axis and apical forechamber views. Secondly, the inferior vena cava or the IVC is interrogated, and then the right upper quadrant, left upper quadrant, and the pelvis is scanned to look for intra-abdominal free fluid. The aorta is then scanned to look for evidence of a possibly contributing AAA, and then bilateral thoraces are scanned to look for pneumothorax. The phase the rate probe can be used universally, but if time allows, you may decide to use the high-frequency linear or curvilinear probe for thoracic views and the curvilinear probe for abdominal aortic scans. For this tutorial, I will outline a more simplified mental model of the information that you're trying to acquire. I'd like you to envision hemodynamic physiology to be composed of 3 parts: the pump, or the heart, the tank, which is the fluid volume or preload returning to the right side of the heart, and then the pipes, which represents the arterial system that perfuses tissues. Let's start with the evaluation of the pump. While this will include peristernal long axis and apical forechamber views, I argue that your go-to view should probably be the subcostal forechamber, as it's likely the easiest to acquire and doesn't require attention to patient positioning. For this section of the exam, you will attempt to answer 3 questions. Firstly, is there a large pericardial effusion that may be contributing to instability? Second, what does the LV systolic function look like? And third, is there any evidence of RV enlargement that may be suggestive of acute pulmonary hypertension? Let's start by addressing the first question. This is an example of a peristernal long axis view demonstrating a pericardial effusion. For the sake of the Rush exam, advanced interpretation of tamponade physiology, including nuances in diastolic dysfunction, right atrial and right ventricular collapse during different phases of the cardiac cycle, is not assessed here. The question here is binary. Is there a pericardial effusion or not? Here is an example of a medical patient with an obvious moderate effusion identified on subcostal forechamber, the view that is the most sensitive for ruling out a pericardial effusion. Clinically, if the patient is sick, the answer to your binary question may imply disposition. Perhaps obtaining a critical care, radiology, or cardiology consultation is warranted based on your findings. The second question pertains to getting a general idea of global left ventricular systolic function. Here is an example of personal long axis view demonstrating a grossly normal left ventricular systolic function. Recall that gross systolic function can be qualitatively assessed by observing, firstly, endocardial excursion, or whether the endocardium moves symmetrically towards the center of the chamber during systole. Secondly, myocardial thickening, or whether the myocardium increases in thickness by at least 40% during systole. And thirdly, septal motion, or anterior mitral valve leaflet tip within 1 cm of the interventricular septum on personal long axis views. Numerous studies have demonstrated respectable sensitivity of the general eyeball assessment for more experienced sonographers. This piece of information is extremely useful in ruling in or out cardiogenic shock quickly at the bedside. For the sake of the Rush exam, you will classify the LVEF into 3 categories: reduced, normal, or hyperdynamic. Here is an example of a grossly reduced left ventricular function. You don't need a comprehensive echo to tell you that this is significantly abnormal. This is from a patient with severe septic-induced cardiomyopathy, gross EF estimated to be 10% on comprehensive echo. Here is an example of a hyperdynamic LV visible on apical forechamber. The myocardium contracting leads to total or near total obliteration of the cavity in systole. In many scenarios, this finding may reflect hypovolemia or an underfilled LV, but this is not specific and could also reflect other insults, including distributive shock, acute PE, or cardiac tamponade. So you will need to put this finding together with additional views, as we will discuss next. Third question you will try to answer is if the RV is dilated. In acute PE, rarely is a clot actually visualized on transthoracic echo. Massive PE is more likely to present with indirect findings of acute right ventricular failure, such as RV dilatation being one of these findings. In an emergent scenario, this finding may be suggestive of an acute PE or conversely, an RV infarct. The RV is normally less than 2/3 of the size of LV in apical forechamber. When the size is equal or larger than the LV, right ventricular failure should be suspected. Here is a normally sized RV in apical forechamber view. Here is an example of a large RV. Importantly, this finding is not specific. If time allows, it may be helpful to look at previous echo reports. A number of causes may reproduce this finding, including chronic pulmonary hypertension. Use this finding with other views in the clinical context. If the history is suggestive and other views demonstrate a plethoric IVC and a hyperdynamic or underfilled LV, the underlying diagnosis may be an acute PE. The next order of business is to classify the status of the tank, or the intravascular preload component that plays a role in cardiac output. We will start by interrogating the IVC. This will help determine how full the tank is, and can give some information about volume status. The infamous FAST exam will help clarify if the tank is leaking intra-abdominally. And lastly, thoracic view will help determine if the patient has a pneumothorax, which may have contributing tension physiology. There is evidence that evaluation of the IVC in terms of its size and collapsibility with the respiratory cycle can make suggestions about intravascular volume status. This view is acquired from the subcostal view. Remember to freeze your image and measure its size 2 cm distal from the RA. Then, use M mode for respirophasic collapsibility. Do this by measuring the minimal and maximal diameter as it varies with the respiratory cycle. The Rush exam will try to characterize the IVC into normal, collapsed, or plethoric. A normal IVC has a maximal diameter between 1.5 to 2 centimeters with some respiratory variation, and this is an example of a normal IVC. A collapsed IVC is one that's small, smaller than 1.5 centimeters, that collapses greater than 50% during inspiration. And a plethoric or a large IVC is one that is greater than 2.1 centimeters that does not vary much with the respiratory cycle. A collapsed IVC is generally interpreted as preload deficiency that may be consistent with hypovolemic or distributive shock. Combining this view with the finding of a hyperdynamic or an underfilled LV will be helpful in building that case. This is an example of a small and collapsible IVC indicating that this patient may be volume responsive. It's important to note that this has to be done on a spontaneously breathing supine patient. Nuances of measurement for intubated patients on positive pressure are outside of the scope of this tutorial. This is an example of a plethoric IVC. It is large and barely collapsing with inspiration. This finding can be indicative of right or left heart failure, obstructive shock, or volume overload. Finding a plethoric IVC together with RV dilatation may suggest an acute PE. With a pericardial effusion, this may suggest pericardial tamponade. In the young patient with sudden onset pleuritic chest pain, there was a significantly enlarged RV in the context of a hyperdynamic LV, and this is the case here of that plethoric IVC. This was in keeping with an acute PE. Always clinically integrate your findings and avoid anchoring decisions on isolated findings. Some words of caution with regards to the plethoric IVC. A plethoric IVC does not imply that patient will not respond to fluid. An example of this will include a pericardial effusion or pulmonary hypertension, which are pathologies that may be preload dependent. The next question with respect to the tank will be to determine if it's leaking intra-abdominally, and this is where the FAST exam comes in. This consists of 3 views: the right upper quadrant, the left upper quadrant, and the pelvis views. And what I will emphasize is that these views can yield invaluable info about medical patients as well as trauma patients, if used in the right clinical context. It is critical to appreciate that free fluid in the abdomen is nonspecific, and this can range from physiologic free fluid, ascites, to infections and gross hemorrhage. Here is a case of a medical patient with spontaneous cause of intraperitoneal hemorrhage post-thrombolysis for STEMI. While this is more common in trauma patients, it can occur in medical patients as well, particularly iatrogenically after percutaneous or endoscopic procedures. Again, I caution you that these findings are nonspecific. If you have a post-lytic patient that is tachycardic with a hemoglobin of 50 and a hyperdynamic underfilled LV and a small collapsible IVC, this positive FAST is going to be a lot more useful rather than an isolated finding. Use this as a data point and clinically integrate it into your decision making. Here's an example of a tachycardic hypotensive patient following a colonoscopy. A rush exam was done in this patient and includes this left upper quadrant view demonstrating intra-abdominal free fluid. Following this finding, a CTA of the abdomen was obtained urgently, which demonstrated a splenic rupture secondary to overzealous manipulation of the colonoscopy probe around the splenic flexure. In the right clinical context with these findings, one might suggest emergent CTA of the abdomen, massive transfusion protocol with surgical and interventional radiologic referral. Pelvic views are recommended here too, but for the sake of brevity for this tutorial, let's move on to additional views. The last question we are seeking to answer regarding the tank is if it's compromised with a pneumothorax. Preload can be significantly obstructed by pneumothoraces with tension physiology, and the binary question here is there lung sliding for the sake of the rush exam? While lung sliding definitively rules out a pneumothorax, its absence is not specific. There are many nuances for thoracic examination that I urge you to learn more about. This exam can be helpful for the medical patient, especially in those for risk factors for secondary pneumothoraces, including asthmatics, patients with COPD, and connective tissue diseases. Also, this may be helpful for those at risk for iatrogenic injury, either from central venous catheter placement or barrier or volley trauma for patients on mechanical ventilation. Here is an example of a patient who developed hypoxia and hypotension following an exacerbation of his asthma. The initially interrogated interspace demonstrates lung sliding, and in the adjacent cephalad interspace, there is absence of sliding. This junction is the lung point, which is pathognomonic for a pneumothorax, as you will recall. In this case, the thoracic ultrasound was paramount in prompt diagnosis and immediate management. So we've talked about the pump and the tank. The last concept I will discuss here is the evaluation of the pipes, also known as the aorta, which may be helpful in the medical patient who is critically ill. What we were specifically interested in here is whether the patient has any evidence of a AAA or an aortic dissection. The aorta is scanned transabdominally in the transverse orientation from the xiphoid process down into the bifurcation into the iliacs. Any enlargement beyond 3 centimeters is abnormal, and anything beyond 5 is concerning for imminent if not already ruptured. Here is an example of a normal appearing aorta viewed distally to the bifurcation, while here is an example of an aneurysmal aorta measuring 5.6 centimeters leading edge to leading edge. Clearly visible is a large mural thrombus with decreasing diameter of the true lumen. An enlarged aorta in a sick patient, especially one with abdominal, back, or flank pain or hematuria, is an imminently rupturing AAA until proven otherwise. Identifying this prompts further imaging if the patient is stable, or a vascular consult if the patient is unstable. Importantly, the majority of ruptured AAAs will not have intraperitoneal free fluid, as they are a retroperitoneal structure. Screening for a thoracic aortic dissection may be more difficult and poorly sensitive, but findings are helpful if they are positive. During cardiac views, attempt to freeze your image during personal long axis view, and remember the rule of thirds. The RV, aortic root, and the LA should look roughly equal. If the aortic root is large, that is suggestive of a possibly aneurysmal aorta. In this case, the aortic root is enlarged. A type A dissection was confirmed on subsequent CT or aortogram. Additionally, look for an intimal flap in the aortic root or in the descending aorta on personal views, and within the abdominal aorta transabdominally. This is an example of an intimal flap in the descending aorta, clearly visible as the luminal, tissue-like echogenicity. The finding of an intimal flap is pathognomonic for an aortic dissection. That was a lot of material. Thank you for sticking it out. At this stage, I recommend that you go back and review any necessary slides so that you are comfortable with the sequence and specific questions you are trying to answer with the Rush exam. Perhaps the biggest challenge is putting all of these pieces together quickly to develop a focused differential for the unstable patient, and thus, clinical integration is key. Here's one resource you can use to help make sense of the data points you've acquired. Cardiac coupled with IVC views can help differentiate different types of shock. For example, a patient with a hyperdynamic or an underfilled LV in a flat collapsible IVC could reflect a distributive shock, for which sepsis is an example, or hypovolemic shock. The IVC findings may be suggestive that the patient may be volume responsive. Further views, such as abdominal views, can help if positive. For example, a positive FAST or a AAA or dissection in the right clinical context could point towards a hemorrhagic source of shock. Conversely, cardiogenic shock will present with a diminished LV systolic function or a heart that is barely contracting. With an enlarged and a plethoric IVC and minimal respirophasic variability, obstructive shock secondary to acute pulmonary hypertension, which may be secondary to PE or RV infarct, may present with a dilated RV, a hyperdynamic or an underfilled LV, and a plethoric large IVC. This flowchart is an example of how to put these views together, and I urge you to come back here and spend some time trying to understand the combination of findings that are suggestive of different causes of shock. I have introduced some of the observational studies that demonstrated some utility of this exam, but you may be wondering if there's any actual high-quality evidence for the exam, and it turns out there is. In the last few years, multiple newer studies have been published to try to make sense of all the primary literature. Here is a recent meta-analysis published on the Rush, demonstrating promising pooled estimates of high sensitivity and specificity for different causes of shock. Multiple other studies and reviews have demonstrated similar findings, arguing towards developing and utilizing this skill set in the critical care setting. Let's bring it home. In summary, RUSH stands for Rapid Ultrasonography for Shock. The HIMAP acronym can help you remember the sequence, or you can think of it as the pump, the tank, or the pipes. Clinical integration is key. Remember to put all of your data points together along with the history and the physical, before prematurely anchoring on a specific diagnosis. The exam was designed to take 2 minutes or less, and there is a decent body of evidence that supports you taking on this skill set. A memorable quote from Salim Rezaie, who's the founder of Academic Life in Emergency Medicine. The RUSH protocol is to medical patients what the FAST exam is to trauma patients. Thank you for watching, and see you next time.